I'll first introduce Professor Lee Wallace. He might be joining us online later on for the Q&A session, but he's pre-recorded a video. He is the editor-in-chief of the African Journal of Emergency Medicine, and he's working at the WHO headquarters as the lead for emergency care. He was also the head of Division of Emergency Medicine of University of Cape Town. His research interests includes emergency care system, emergency care in low resource setting, triage, pre-hospital care, policy, leadership, and management. Professor Lee Wallace is going to talk to us about leading and working with different health systems in Africa.
Good afternoon, everyone. This is Lee Wallace. I'm the lead for emergency care at World Health Organization headquarters in Geneva. Thank you, Professor Graham and team, for inviting me to be part of this symposium. I'm really hoping I can join you live on Monday, but here's a recording just in case. I'm sitting in my hotel room in Baghdad, but by Monday afternoon I will be in Kurdistan, and I'm not sure about the connectivity. So anyway, we will see. I was asked to talk about emergency care systems in Africa, but since the start of the year I've been in this permanent position in headquarters, and so I need to speak from the WHO lens. But I will certainly be making a lot of reference to my previous life, which was with the African Federation for Emergency Medicine and with the University of Cape Town, really focused on improving emergency care systems in Africa. You'll see from the homepage of the AFEM website, which is afem.africa, if you're interested in going to look, and I would encourage you to do so. You'll see that you can find out on there about the sort of work that AFEM does and the resources that are being produced. We started AFEM in 2009 in response to an increasingly identified gap in health systems on the continent and increasing numbers of requests for support from academic organizations, partners, and ministries of health. And we started very small. And AFEM, despite all the great work it does, remains very small. It has its executive structure around the president and the committee, obviously. But the sort of workforce as it is a very small team that's currently based in Cape Town. And they do remarkable work despite that challenge. What you won't see on the website is the work they do in support of WHO with regard to implementing our tools, and that's a lot of what I'll talk about today. But other things that you'll see from AFEM, there's this almost 1,500-page second edition of the Handbook of Acute and Emergency Care, which is oriented to the low-resource setting. The journal, which is in its, I think it's 12th year now, with an impact factor, which it's in the it's in a good range for, I think it's only the second year that the impact factor is there. You see it's 1.37 last year, and it really produces work oriented to African context. There are a number of other things like the African Conference on Emergency Medicine, which is coming up in Ghana in November this year. I think that's going to be the 7th such conference every 2 years. And if you are interested, please, afem.africa, go take a look. But we're going to swing now to WHO and how we've produced tools and what those tools are and how those tools then make impact in Africa to close the circle. So within WHO, there's divisions. So you'll all be familiar, I'm sure, with the WHE program, the World Health Emergencies. On the other side, there's the Universal Health Coverage divisions, and within one of those that covers the life course, there's the Department of Integrated Health Services. And within that department, there are units. The Clinical Services and Systems unit is where you'll find emergency care. And actually, the columns on the right, primary care, emergency and critical care, and operative care is part of what we focus on. So it's really about integrating and organising clinical service delivery, packages of care, models of care, pathways, movement up and down the referral pathway, and this primary and ecosystem approach. So while my title is Lead for Emergency Care, I also cover critical care in that remit. And we can have a separate conversation about how the lines between emergency care and critical care are blurry, and policymakers often struggle to tell where one starts and one ends, and as I do. And so we're trying to take what we call an ecosystems approach now, where we're looking at the whole of that, the service delivery that's required for the acutely ill or injured patient. And we, some of that is clearly emergency care, but we need to take a slightly wider approach to that. We call that primary, emergency, critical and operative care with palliative care cross-cutting. We call that approach integrated clinical care, ICC or IC2. So our IC2 approach is that we take a standardized approach to patient journeys through the system. So whether you're in primary care, emergency care, critical care, operative care, you will have a standardized approach that is consistent across all of the different parts of the platform, including sort of standardized decision-making tools, process tools to support your function, symptom and syndromic-based approaches to conditions, and right up to sort of data and quality management with our what's currently called IRTEC, the International Registry for Trauma and Emergency Care, but it will be renamed, but it is our clinical registry to help with facility level or national level quality improvement activities. So let's just step back a second and work out why we are actually focusing on emergency care as an organisation. And I'm sure those of you in the audience who are practicing emergency care on a daily basis, whether you're a pre-hospital provider, a nurse, a doctor, some other practitioner, sure you recognise that what you do makes a difference, but I wonder how many of you have stopped and thought about why you're there in the system in the first place. So Olive Kobrisinge, who's a trauma surgeon in Uganda, wrote this in the WHO bulletin many years ago, and I don't think there's a better way to say it, that it doesn't matter really whether our systems are prepared for emergency patients. They're coming. They'll have their car crashes and heart attacks and strokes and broken legs, and they will come to need help whether we're ready for them or not. So it's really incumbent on us to be ready to help. And you can think about arguing from, for instance, the burden of trauma globally. Most of trauma is not managed surgically these days, but it certainly is managed through emergency care. This often surprises people that the burden of trauma in terms of the deaths per year is still massively ahead of HIV, TB and malaria combined. The World Bank's DCP project, the Disease Control Priorities, did some very interesting modelling that suggests that over half of deaths that occur each year in low middle income countries, all deaths that occur in those countries each year, over half are impacted directly by emergency care systems. So if you put a better emergency care system in place, you can potentially impact on over half of deaths in low middle income settings. And that's supported by a couple of papers, one from Emergency Medicine Journal and one from the BMJ Global Health, using slightly different global burden of disease data sets, but coming to the same conclusion that the lower resourced country, the higher the proportion of deaths that are impacted by emergency care or are from conditions that present as emergencies. But either way, it's over half. And then one interesting piece that isn't yet in print, but is a PhD from the University of Cape Town last year, looking at emergency care systems in Africa with some cost effectiveness work showing up to 418% return on investment, which is highly cost effective. Just a slightly different way of looking at the same issue, which is that, again, a different model, but half of deaths and 40% of disability due to emergency conditions. In terms of cost effectiveness, in addition to the return on investment, we have this really interesting work also from DCP, from the World Bank. So antiretrovirals for HIV, $922 per year of life gained, and most policymakers and funders will happily accept that as a decent value for money and will invest in antiretrovirals, quite rightly. But it's often missed that even if you pay paramedics and EMTs a salary, and you have a fully professional organization in a rural area with a reasonably low workload, the cost per year life gain is a quarter of that for antiretrovirals, more or less. And it's 10% if you do that in a city with a higher workload, and it's almost nothing if you do a combination of professional staff and community first aid responders. You can get that cost right down to the $7, which is basically almost free. It's a very cheap and cost-effective intervention. So there's a burden of disease that drives the need. There's also global mandates, so the 17 Sustainable Development Goals to be achieved by 2030 to make the world a better and safer place. And each of those has a number of targets. Goal 3, good health and well-being, is where we usually think about health system impact. But if you think about the emergency care system, it actually impacts on 10 targets across mostly Goal 3, but also in 11 and 16. And this is your Ministry of Health really should be working towards the SDG targets across the whole government, actually. And so this is a very powerful advocacy tool to make an argument for investment in the emergency care system. If it helps hit the targets, then it helps to achieve the government's objectives. I've highlighted the road deaths there because the original target was 2020 and we didn't manage to make that globally, so that's been reset to halving road deaths by 2030. There are other reasons for having emergency care systems in place. There's the basic human right argument, and there's a number of conventions and statements from the United Nations overall about health and access to health. And then WHO's work, what we do and our strategy comes from our member states, the 194 member states at the World Health Assembly. And they pass resolutions that's held each May. And the one that we were really working to primarily was this top right 60.22 from 2007 that really said you should have an emergency care system in your country. But it was lacking detail really about what to do. So after Terry Reynolds was in post in a slightly different department, but in this emergency trauma and acute care function as the lead for emergency care from about 6 years ago, she worked on trying to lead a process to define the emergency care system. That ultimately got spelled out in this World Health Assembly resolution in 2019, 7216. This is a very powerful mechanism to encourage countries to invest in their emergency care system. And we started to see a real increase in requests for support and strengthening of emergency care. And then, of course, COVID came along and stopped everything for a while, but also made countries very acutely aware that the big gaps in their healthcare system exposed by COVID are around emergency and critical care. And so there's been a huge increase in countries looking to strengthen the emergency care system. So we have some tools to help support that. And we build our tools around the framework, which this is what underpins that resolution, the details of this framework. So we consider emergency care in 3 parts: care at the scene, during transport, and at the facility. So at the scene, there are a number of things that should happen around being able to activate the system, maybe a bystander giving first aid if they've been trained, but certainly receiving advice on the telephone. When you get to transport care, an ambulance should have certain minimum requirements met within it, including, and not least, 2 people in it. If there's only a driver, it ceases to be an ambulance and becomes a taxi. And then some facility-based components that need to be in place for effective emergency care. And we always said that includes early inpatient critical care and early inpatient operative care, but without really further defining that. We are now, with this ecosystem IC2 approach, we are working very hard on defining that and putting there's tools that I'll show you now for emergency care. We're working on very similar tools for critical and operative care. So the system also needs to have legislation and regulation underpinning it. It's not just about equipment and medicines and so on, but the whole thing is built on the WHO's health system building blocks. And you can use this framework and the two infographics that go with it, and of course all of the supporting material behind it, to help set minimum standards. Now, I'm aware that Hong Kong has a very well-established and effective and strong emergency medicine led system with the college, obviously, and the academic partners and the universities. But it's always worth looking at the system and trying to determine where the gaps are. And this is a very useful tool to help do that. Based on the work that was done in the early years of emergency care at WHO, we received some foundational funding from the AO Foundation to establish what was called the Global Emergency and Trauma Care Initiative, GETI, which was conceptualized in one way initially, which was about supporting countries to provide quality care and showing evidence of impact, which would allow us to advocate for that. We've taken a slightly different direction with this now, and it's really an umbrella term for all of our emergency care activities. And when we provide support to countries, we try to do that through advocacy, which we're doing on a global level, assessing and planning, so supporting countries to identify the strategic priorities that will strengthen their system, working with partners, academic partners, collaborating centres, professional societies, to provide support. And then the other three are really about the tools that we have: clinical care training, process guidance, quality improvement. I will come back to. In some countries, we are doing an impact assessment. So we have, for instance, we might pick 8 facilities across the country where we measure baseline mortality and process for 6 months, 12 months. And you see there the 6 sentinel conditions, which are across the big groups of burden of disease, so trauma, asthma for non-communicable disease, along with DKA, pneumonia and diarrhea representing both communicable disease and childhood disease, and postpartum hemorrhage. Then we implement the toolkit, and then we measure the impact again on the mortality and process. And I'll come back to why we were successful in obtaining funding to roll this out later on some data that we haven't yet published. So as I said, when we work with countries, we do this emergency care system assessment to help identify gaps. We identify the priority actions, and then we help implement those, the highest priority interventions. And our tools are across several columns, really, pre-hospital system tools that we have available. And again, these, I'm focused on emergency care right now for this audience. We're repeating this for critical care, for instance. We have a lot of work with the emergency medical teams initiative to support surge capacity, registry, standardized clinical forms for medical notes to help quality improvement. We have a number of, currently we have the basic emergency care course, which is for frontline providers that have seen emergencies but haven't had formalized training. And we've taught over 20,000 people over the last few years, even continuing during COVID, which has been great. We have a management course for emergency unit leadership, but we also have other courses coming, like an advanced trauma course, critical care course, and so on. Happy to provide any details about those. We have a number of clinical process tools, like a triage tool, and then some regulatory toolkit. And they really split into the sort of assessment. So there's a pre-hospital assessment of your EMS system. There's a emergency unit assessment tool to work out the strategic priorities to improve your emergency unit. And then there's the training, the process tools, and the data and quality improvement tools. Really just a slightly different way of conceptualizing the last slide. So here's some of the things that are in the toolkit. The basic emergency care course, for instance, which is a open access, is a 5-day or sometimes 4-day short course for those in resource limited settings who haven't had training in emergency care. It takes a syndromic approach. So it's the ABC approach, and then trauma, and then approach to difficulty breathing, approach to shock, and approach to altered mental status. So it's not disease oriented, it's rather presentation oriented. There's a triage tool, adults, children, pre-hospital, in-hospital, and surge. This is the integrated interagency triage tool that's developed with ICRC and Médecins Sans Frontières. And we've had some studies starting to come out now to validate it. And actually the tools were developed by global consensus. We've brought together all of the leads for the different, so the South African triage scale, the ESI, Manchester triage, Australasian triage. We brought people together and gained consensus on this. So it is a globally developed tool. So just to finish off by coming back to Africa, say part of the reason we're so enthusiastic about rolling these out internationally is not just that we believe in it from an emergency care point of view, but we studied 2 district hospitals in Uganda and 2 in Tanzania back in 2016-17 and did very simple things. We really didn't invest money. It cost about $3,000 per site. We brought together all of the things that were already in the hospital to treat emergencies and really just brought them together onto an emergency trolley made effectively in a resuscitation area with pieces of card and just reorganization of what was there already with a local champion. We introduced triage, we introduced basic emergency care. And you see there Dr. Kananzi and Violet, the nurse from one of the hospitals there in Uganda, who were the local champions. A year of baseline data on these conditions, we implemented the toolkit, and a year of post-implementation data. And somewhere, really varied by condition and by hospital, but somewhere between 30 and 70% mortality reduction. So this is very cheap and it's clearly highly impactful. So this is what we're trying to do, and we are actually the number of countries where we're involved right now with toolkit implementation, supported in Africa by AFM in large part, but obviously always working with the Ministry of Health and with the WHO country office and our regional partners in the Africa office or the Eastern Mediterranean office. And then with any academic partners or development agencies and so on, we are implementing this in very many places. So, for instance, we just ran a very successful 7-country Train the Trainer course for the basic emergency care. We ran one in Ghana and then one in Nairobi. We have a number of others coming up. And we've had ongoing implementation despite the COVID pandemic. It's been very successful and very well received and very impactful. And I am, of course, always happy to answer any questions and to have people contact. So again, thank you for the opportunity, and please don't hesitate to reach out if we can help with anything. And I really hope that you're not listening to this recording and that I was able to join from Kurdistan.
So it's great to have heard from Professor Lee Wallace about the development on the WHO front, and it's great to hear that emergency medicine is getting traction on the global level.